is the 2 standard deviation and the 3 standard deviation, or the 97th centile is above
We are not able
97th
to see
centile is
your
taken
slides.
as overweight. Sorry, cannot hear you.
We are not able to see your slides. We are only able to see you.
Oh, is it? Okay, okay. Sorry, sir. So I thought the slides are visible.
No,
I'm
the
sharing
slides are visible, sir. 1 second. Yeah, slide is visible, sir.
We can see it.
Okay,
I
so
can see
I
that.
think if most of you can see it, then maybe it's an individual problem why you cannot see the slides. Yeah.
I
So the
request
main,
sorry to interrupt, sir. I request everyone, can they chat in the box that they can see the screen so that we will have numbers. I think most of them can see the screen, sir, so we can continue.
okay. So regarding diagnosing obesity, generally we see children 5 to 18 years, the growing age. So the BMI for age IAP growth charts need to be used. And now the combined charts also there from 0 to 18 years, the WHO and the IAP combined growth charts, in which you don't need to calculate the BMI at all. You can put the weight and the height, join the line, and on the top left corner, you will find if they're overweight or obese. So you, as pediatricians, it's much easier to use and takes much lesser time. So that is the IAP WHO combined growth charts from 0 to 18 years. And importantly, in addition to this, we can also use the waist circumference charts. There are waist circumference charts given by IAP for 5 to 18 years kids. And if the waist circumference is more than the 70th percentile, it's considered as risk of metabolic syndrome, and those children should be again be under careful follow-up, and that needs to be addressed as well. So in addition to the IAP growth charts, the IAP BMI growth chart, and also the 0 to 18 years combined IAP WHO growth charts, we can also use the waist circumference charts in children to see the risk factors of central obesity and their future risk of metabolic syndrome. So this is how we plotted the weight, the age on the X column, the horizontal line, and the BMI on the vertical or the Y-axis, and then join the line and see if the child is in the obese or overweight category. Now, the more common causes of child obesity are sometimes genetics, and with a family history, genetic cause of obesity or monogenic cause of obesity sometimes, but most of the times it's sedentary lifestyle or junk food, and high sugar and fat containing diet, overeating, and rarely there are also medications which can cause children to get obese, whether we take steroids or anti-epileptics or some other conditions which can cause weight gain, and medical conditions per se, endocrine problems or other systemic illnesses which can cause obesity as well. And why do kids get fat? Most of the kids that we see are exogenous obesity or simple obesity. And obesity in these children does not occur overnight. It develops gradually when there's disturbance in the energy balance, when the intake is more than expenditure. So when the calorie intake is more than calorie expenditure, then it gets stored as excess fat in the body, and that's when children become obese. So, and the energy expenditure, we need to look at the resting calories, the activity levels, the exercise levels, and compare it to the calories that are consumed daily. So, if it's a multidisciplinary clinic where where the dietitian is looking into calories consumed and the calories expended is calculated entirely, then it's probably there's a better way to manage these kids in giving them more time to understand their day-to-day calories consumption as well as expenditure, and that can help these children in terms of weight loss. So child obesity has health implications which are either immediate, intermediate, or long-term. And we need to know that type 2 diabetes is a common consequence of child obesity, either in adolescence or early adulthood or intermediate or middle age. Hypertension is another one. Then dyslipidemia can occur because of the wrong dietary habits and as well as lack of exercise, and obesity can lead to dyslipidemia. And a little later on in life, then they can have coronary heart disease, early anginas, osteoarthritis due to the weight bearing on the knees. They can have respiratory problems like obstructive sleep apnea, and there are also mental health issues like depression, poor mental health, learning problems, emotional disturbances, loss of self-esteem, which Dr. Sneha Kulkarni will tell us in detail more in the third talk today. So almost every known medical problem, physical or mental, is made worse by obesity. And again, when it comes to the diagnosis of metabolic syndrome that we commonly talk about, the IDF has given us criteria to diagnose metabolic syndrome in children aged 10 to 16 years. The criteria is presence of abdominal obesity, which is the waist circumference more than 90th centile, with two of the following: either a triglyceride more than 150, or HDL less than 40, or fasting blood sugar more than 100, or systolic blood pressure more than 130 millimeter of mercury, or the diastolic being more than 85. So again, this is just a clinical term used to classify them as metabolic syndrome, but the treatment and other aspects will most of the times remain the same when we're dealing with any other child. Now, when we come to obesity and how to approach for the cause, obese children need to be assessed in terms of their growth, the weight, and the height. So we should look at the puberty, regarding the onset of puberty or delayed puberty, what stage of puberty the child is in, and also when this obesity started. Is it recent onset or is it long-standing obesity? So based on these three things, if we find that the growth is normal, the puberty is normal, the onset is also long-standing, it could be likely exogenous obesity, and these children should undergo complication screening, which is most important, to screen them for disorders or diseases which can occur due to the obesity. If the growth is slow, if the height is less, the weight is more, then it points more towards an endocrine workup being needed, looking at the thyroid functions, looking at the cortisol levels, and looking at the parathyroid hormone levels, because the pseudo hypoparathyroidism can also cause these children to be obese and also short. And if the obesity is very early in onset, if it started below 6 months of age, then we should look at if there's any associated developmental delays. Are there any dysmorphism? Does it fit into any syndromic obesity or monogenic causes? And if yes, if there's development delay, if there's dysmorphism, then one thing is Prader-Willi syndrome is quite common. So we should work them up for Prader-Willi syndrome. And if we don't have development delay or dysmorphism pointing towards Prader-Willi syndrome, it could be other cause of obesity, monogenic obesity, in which a targeted clinical exome sequencing can be done to look for the genetic cause of obesity. With the availability of genetic tests, now we're able to diagnose more other genetic causes like MCSK mutations, POMC mutations, as well as leptin receptor defects, and so a lot of other things can also be identified. Some of which have treatment in terms of setmelanotide is a treatable is a drug which is available to treat some of these causes of genetic obesity. The red flags which pediatricians should know are mainly poor growth, delay in puberty, and developmental delay needs workup for organic causes. Again, dysmorphism, hyperphagia, early onset appearance, which again points towards Prader-Willi syndrome. If there's headache, visual symptoms, neurological symptoms, it could be hypothalamic causes, CNS causes. So it needs to be worked up again and carefully looked at. If there's skin bruising or striae or skin hair changes of hirsutism, then it could be Cushing syndrome, either exogenous or endogenous. So these are all the pathological cause of obesity, which is rarer, though they need to be looked at, and we should know them so that we can look out for these conditions in addition to the normal simple obesity. So when do these children need a referral to pediatric endocrinologist? Is when their onset of obesity is early, before 5 years of age, where the monogenic causes are more likely, genetic causes are more likely. If there's delayed growth, puberty, or development, then we should look for endocrine workup, and they need to be referred. If there's dysmorphism, again, it could be monogenic causes, so Prader-Willi, or Bardet-Biedl syndrome as well. So these are some of the things. If there's neurological features as in rapid progression, we should look at hypothalamic obesity, any space occupying lesions near the organic cause near the pituitary and the hypothalamus. And we should also, when they have complications of obesity, such as type 2 diabetes or obstructive sleep apnea, then they need to be undergoing a more intense management, where multidisciplinary care with a pediatric endocrinologist, with a mental health specialist, a good dietitian, and a regular follow-up with will help in such a case. Along with other specialists whenever required, like a pediatric gastroenterologist or respiratory specialist. And when they have mental health issues not responding to lifestyle measures, again, it becomes necessary to refer these cases early for us to intervene with a more stringent or a more multidisciplinary, a more stricter approach in what we can do, giving more time to these kids and doing better. Let us add more colors to the life of these kids and prevent childhood obesity. We come to the end of this talk on causes and the consequences. And I pass on the mic to my colleague, Dr. Monica Reddy, for the next discussion on the management aspects. Thank you, everyone.
Thank you, Dr. Rahul sir. Good evening, everyone. I'm Dr. Monica. So let me first share my slides for today. Hope my slides are visible.
Yes.
Yeah, thank you so much. So, thank you, Dr. Rahul, for the wonderful oversight on the causes and consequences of pediatric obesity. And I'll be taking the next part, which is the evolving landscape of childhood obesity management, which is like diet and exercise are the basics of management, but what more is coming and what are the latest updates on it? So let me begin with this theme of the World Obesity Day today. So the theme is Changing Systems, Healthier Lives. I say that this is a very beautiful and an impactful theme because, we can't just blame a person for being obese. There are a lot many factors at the level of the individual, at the level of the family, community, school, the government policy, the food policies, the media, everything which need to be changed. So hence the theme for this year, they say that, we have to change the systems. So let's put a spotlight on the systems and not the people that need to change. So with this, let me tell the outline of my talk today. So I'll be going through the first basics of diet and exercise management of obesity, prevention of obesity, and then a brief on structured weight management plan, how a disciplinary team can deliver a structured weight management plan, then management of comorbidities, pharmacotherapy, and pediatric surgery. So coming to the management, I think all of us, we do practice it in our clinics on a day-to-day basis whenever we handle children with obesity and overweight. So the first being dietary modification. So the dietary modifications always are individualized, tailored to the family needs and family approach. So, always the diet modifications are first like assessing like what the family eats and how we can make healthier versions of the same diet. And also some behavioral therapy we do discuss, like having meals together, like no screen time. So these are the general. So on the diet principles, I would like to comment on this plan of 5210, which has been endorsed by IAP for diet. So which says that, a child should be eating at least 5 fruits and vegetables per day, have less than 2 hours of screen time, have at least 1 hour or more of physical activity, and 0 sugary drinks. And next is physical activity. And then beyond that, if the lifestyle changes or not bringing about a change in, say, about 6 months, then we refer to the structured weight management plan. And beyond that, if the child has some comorbidities or it's a very severe obesity, which is not being managed even with the structured weight management plan, then we advise for pharmacotherapy, and in the rarer cases, go for bariatric surgery. So if you can see, this is a healthy plate method. I think this is a very nice way to explain to the child and the family. And so this includes like, we can ask, this is our regular 6-inch plate, which can be divided into 4 parts. And only 1/4 of the part, if you can see, includes the grains and starchy vegetables. The rest 1/4 of the plate should have a good source of protein, and half of the plate should be filled with vegetables and have good amount of healthy fats and the dairy products, low fat milk and yogurts. And if we see the Indianized version of this, I think I came across a wonderful article which suggested that the Indian thali system was always, built on the idea of giving this balanced meals. Because if you see in our healthy plate method of Indian thali system as well, usually we see like more of the vegetables, 2, 3 varieties of vegetables, some rasam, and probably like, a 1/4 part or a little lesser than that, inclusive of rice and roti and the proteins. So usually the proteins are the part which are lacking in the Indian diet. So I think it will be good to always advise the families that conscious efforts have to be made to include a good amount of protein in the diet as appropriate as per the culture of the family eating habits. So physical activity, coming to the physical activity, it has to be tailored to the age, gender, preference, socioeconomic status, and fitness level of the child. And important, I would say, is the barriers to be addressed. Because many times when we just advise, okay, the child has to play for 1 hour daily, and the family tells that, we stay in an individual independent house and we just stay by the roadside, and I don't think I can send my child to play outside. So I guess this is very important to understand, like what are the challenges of the families, like what are the barriers the child is facing to go out and play. And then we have to give them a more individualized and a more realistic or a practical physical activity goal to be done. And individualized goals have to be set. So I'll be dwelling more on the physical activity in the structured weight management plan as well. And if there is any physical disability, example, a slipped capital femoral epiphysis, that needs to be ruled out. And so usually what is the recommendation for the amount of physical activity? So older kids, IAP recommends moderate to vigorous aerobic activity for at least 60 minutes per day, along with resistance exercises. So like weights or using body weight as the weight, at least 20 minutes over 3 days per week. These are effective. In infants, they're encouraged to remain active throughout the day through activities, whatever they play. Reaching out, grasping, pulling, pushing, floor play, crawling, etc. in a safe environment. Toddlers should also have more hours of physical activity, and the recommendation is minimum at least 180 minutes a day. And coming to the prevention is the best policy, because when we try to understand the factors which have caused the obesity, so it starts from the antenatal period itself. So I think the prevention has to start from the antenatal period itself. So promotion of healthy maternal nutrition and weight status at reproductive age. Then exclusive breastfeeding till 6 months of age and continue till 2 years and beyond. And IAP, so in unavoidable situations, the formula feeds have to be started, but IAP recommends, if available, a pasteurized donor human milk would be a better option. And when we start the complementary food, so fresh homemade complementary food starting at 6 months are preferable, avoiding extra sugar for the first 2 years of life and low salt till first 1 year. And avoiding any sugar-sweetened beverages, packed fruit juices, or packaged food. It's always preferable to give a whole fruit than a fruit juice, and promote responsive feeding. So sometimes families do practice forced feeding, or we call it, they also call it for the fear that, the child may be not gaining enough weight. So usually forced feeding has to be avoided. And also we do tell the child that, you have to finish your plate at the end of his meal. So let's change that version and say that you just pick the portion that you want to eat. So probably you can start with a smaller portion size, and it's not compulsory to finish your meal if you don't feel so. So listen to your stomach. So it is a responsive feeding, go as per the appetite of the child. And sleep is very important, because insomnia has been found to be a causative factor of overweight and obesity. So the recommended sleep duration for different age groups has been defined by IAP. And I think we as pediatricians must promote it, that 0 to 5 years should have at least 11 hours of sleep, 5 to 10 at least 10. And 10 years and above should have at least 9 hours of sleep. And there have been some recommendations on the screen time as well, that no screen time up to 2 years of age, and maximum of 1 hour from 1 to 5 years, and 2 hours from 5 to 10 years. And beyond 10 years of age, they have to be balanced with their specific developmental goals. So what is this structured weight management plan? So when we are prescribing our diet and exercise plans and still we are not seeing any change in the weight reduction. So I think here is where we need a more structured plan for the child, and here a multidisciplinary team can help, which comprises of pediatrician, the endocrinologist, psychiatrist, dietitian, a fitness trainer, social worker, and pediatric hepatologist, pediatric pulmonologist, depending on what the comorbidities the child is having. And what is the ideal goal is a gradual weight loss is recommended. So ideally, if a child is less than 6 years, the focus should not be on weight loss, but on weight maintenance. Beyond 6 years of age, if it's a child with severe obesity, then definitely a gradual weight loss plan can be recommended, and which would be like approximately about 0.5 kg per month for 2 to 5 years and 1 kg per week for older children and adolescents. And here we need the help of dietitian, because here we would be recommending energy restricted or a calorie restricted supervised intensive dietary interventions, which may include like very low carbohydrate diets or low energy or low glycemic diets under supervision. And this again has to be individualized and tailored as per the medical comorbidities of the child. For example, if this child is already also showing dyslipidemia, then probably we also have to advise a diet which is lesser in the saturated fats and also restrict the amount of fats. So something like we call it a child 1 and child 2 diet. So the diet has to be tailored as per the child's needs and the metabolic his issues. Now coming to the exercise. So even this is a kind of an example, like how do we give a graded plan or a stepwise plan of the exercise? Like for example, a severely obese child initially can do non-weight bearing exercises like cycling, swimming, or rowing, sitting at one place. And once like his stamina or endurance builds up, and after a month or two, he can more focus on his core and postural activities and build up his cardiorespiratory endurance as yoga, brisk walking, lifting weights, etc. And when he's again accustomed to this amount of activity, then go further for bone and muscle strengthening activities as jumping, skipping, or participating in sports. So this would be very important to give a very tailored plan for the child and then plan on his weight loss goals. So simultaneously, we have to be managing the comorbidities, the different comorbidities what Dr. Rahul just mentioned, and dyslipidemia, diabetes, hypertension, the steatotic liver disease, PCOS, OSA, depression. First step would be lifestyle modification changes. And if in 3 months, like we are not seeing any change, then definitely probably we may have to take the help of a specialist as well as give pharmacotherapy for the respective comorbidities. Now, coming to the pharmacotherapy. So pharmacotherapy, when it is recommended, is if a comprehensive lifestyle modification program doesn't give the appropriate results in about 6 months to 1 year. In adolescents, especially who are more than 12 years, having class 2 obesity with immediate or life-threatening comorbidities, or a child with class 3 obesity. So class 2 obesity is more than 120% of the highest BMI, and class 3 is more than 140% of the BMI. So these are the different medications. So let me go through the most commonly used ones if we are using for a child. So metformin is not approved for the treatment of obesity per se, but it is used for the treatment of type 2 diabetes, also sometimes as an adjunct to prevent the weight gain in girls with PCOS or the children who are on antipsychotic medication. So it works by reducing the hepatic glucose production, decreasing the intestinal absorption of glucose, and increasing peripheral insulin sensitivity. But also it does come up with some side effects as nausea, vomiting, vitamin B12 deficiency, diarrhea, and bloating. So there have been trials which have been conducted in teens between 6 to 18 years, and also in a cohort of children who were between 6 to 12 years of age, wherein they saw that, but always please remember that the pharmacotherapy has to be done in addition to the lifestyle changes. Because once the pharmacotherapy started and the lifestyle changes are not happening, then I don't think like we are going to see any positive change. So it's very important to keep the family and the child motivated to continue his lifestyle changes and along with this pharmacotherapy. So in these trials of metformin, they found that for a period of about 12 months, they saw about a change of about 1 kg per meter square, about a BMI 1 kg per meter square reduction. So I would say that metformin, like if any comorbidities are associated, you can start, but just for the weight loss per se, maybe it's not as great a drug. Then second medication is orlistat. It's a gastric lipase inhibitor. So it inhibits the fat absorption. It is approved for more than 12 years, but then it does come up with a lot of side effects, especially which restrict its use, like steatorrhea, fecal incontinence, and fat-soluble vitamins deficiency. So orlistat also in the trials have resulted in a BMI reduction of about 5%, but the main side effects because of the malabsorption were the limiting factors for its use. Now the latest ones, the glucagon-like peptide analogs have been in the news for some time. I think the celebrities are using. I don't know, like medical or non-medical indications for them. But in the children, like there are two GLP-1 analogs which have been approved, liraglutide and semaglutide. So how do they act is they reduce the gastric emptying, and also they have some effect on the CNS system, which suppresses the appetite. So liraglutide and semaglutide both are approved for children who are above 12 years of age. So liraglutide is given as a daily subcutaneous injection. Semaglutide is given as a weekly subcutaneous injection. And they do come with their set of side effects, as some gastro side effects as vomiting, nausea, abdominal pain. And especially with the liraglutide, there can be increased chances of medullary cell thyroid carcinoma as per the literature. So both of them in the studies have reported about 4 to 5% reduction in the BMI. They have been really helpful actually. But then the limiting factors always would be like once the medication is stopped, there is going to be the rebound weight gain. So, the when to stop is not clearly defined, but if the family is well motivated enough and can give these GLP-1 analogs for about 6 months and then can stop in between and see how it goes. The other medications are phentermine and topiramate. So phentermine is approved for short-term use in children more than 16 years of age. So it's a norepinephrine reuptake inhibitor, which suppresses appetite again. And the side effects being hypertension, dizziness, dry mouth, insomnia. Topiramate is approved for binge eating disorder in adolescents or in adults more than 18. So it also suppresses the appetite, but especially because of its teratogenic potential, caution has to be used. So out of these medications, I think the metformin, orlistat, and the GLP-1 analogs, I would say, are some of the commoner medications that are in use amongst the pediatric endocrinologists, which along with the good lifestyle changes have definitely brought about some good BMI reductions. And these are the other drugs which are used in certain situations. For example, in Prader-Willi syndrome, growth hormone, octreotide is used in hypothalamic obesity. Leptin needs to be used in leptin deficiency, but I would say that leptin, setmelanotide are not available in India. It's a big challenge to get them. And lisdexamfetamine is used for binge eating disorders. I think out of these conditions, Prader-Willi is something which we see commonly, and it's very important, I think, to remember that growth hormone has to be initiated at the earliest, because this does help in redistribution of the fat percentage of the body and also helps in a cognitive improvement for the child. Surgical management may be offered in children who are older than 12 years of age with class 2 and associated comorbidities, or class 3 without comorbidities, only after failure of a proper trial of intensive lifestyle changes and pharmacotherapy for at least 6 months. So Roux-en-Y and sleeve gastrectomy are the most commonly used procedures, but they do have some complications as cholestasis and malabsorptions. So micronutrient supplementation would be very important. And it was also important that post-surgery, the lifestyle changes have to be continued. So with this, I would come to my last slide. So this is a very nice IAP guideline given for the pediatricians. So when we classify a child with BMI as per the BMI charts into overweight, obesity, or severe obesity. So if it's an overweight child, try the lifestyle changes, which is called as prevention plus for 6 months. If the child is able to maintain his weight or there's a BMI reduction, continue the lifestyle changes. And if you see that there is no decrease in the BMI, then you refer to the structured weight management plan. So similarly in obese children also, like give lifestyle modification trial for about 6 months, and then you may refer to the structured weight management team. And if meanwhile you see that there are any comorbidities or there is a positive family history of metabolic complications in the family, then I think it's very important to screen and treat the comorbidities simultaneously, and needs to be referred to the multidisciplinary team. And this is severe obesity. The first trial would be again lifestyle changes for 6 months. If doing well, then please continue. If not doing well, then to a structured weight management plan. And again, in case of comorbidities, would need pharmacotherapy or the bariatric surgery. So with this, I would like to end my talk. And these are my references. And I think these are very good reads, especially the IAP guidelines on obesity, which came out in December 2023 for all of us. So please go through. And with this, I would like to end my talk. And I would like to hand over to Dr. Sneha Kulkarni. Thank you.
Thank you so much, ma'am. And now over to Sneha, ma'am.
So much. Thank you, Monica ma'am, and thank you, Rahul sir, for including me in the panel today. Hope I'm audible.
Yes, Sneha, you're on.
Ma'am, you are audible.
Let me share the screen. Is it visible, the PPT?
Yes,
ma'am.
So, good evening, everyone. I'm Dr. Sneha Kulkarni. I'm a child and adolescent psychiatrist at Ankura Hospitals, and also I'm a cognitive behavioral therapist. So today I'll be discussing the importance of mental health in treating obesity, because it is often the missing link, right? So I think I'll be discussing about the emotional mental health aspect as well as the social aspects of obesity, right? So coming to the first slide. Okay, I'm not able to change it. Just a minute. Yeah. So coming to the overview, once the children come to me, usually the children come to me and the parents come to me, and they're so scared. The parents are scared that why we need to go to a psychiatrist. Usually if the children are less than 10 years old, they don't bother, or if they are adolescents, they would be like questioning themselves, why am I going to a psychiatrist? Why do I need to meet her? Or am I mad? Such questions will come, right? So the first thing that I tell to them is I start is by asking them the definition of health, right? So it according to WHO, it has 3 domains. The first one is the physical health. We all know about it. The second one would be the mental health, and the third one would be the social well-being. So there are 3 domains, and all these are interlinked with each other, right? So, but often ignored, right? The mental health, the social well-being part is often ignored. So this is how I start my conversation with the parents and the children, and then they get a little confidence to even just listen to me, or go through the consultation, right? So here we can see some statistics worldwide. So there are 39 million children under the age of 5 who are overweight, who were overweight in the year 2022, right? And children with obesity are 55% more likely to develop depression in adulthood, right? These are some of the statistics. That is why this shows the importance, right, of mental health in treating obesity.
Dr. Sneha, we lost your voice.
Um,
Dr. Sneha, are you connected?
I think she got disconnected.
Yeah.
We'll just wait for her to rejoin.
Yeah, I'll just give her a call meanwhile.
Yeah. Meanwhile, if any doctors have any concern or have any questions for Dr. Monica, you can ask.
Yeah, hi ma'am. I'm Dr. Jyotsna. I'm an infection control consultant at Ankura.
Yeah,
I
hi,
just
ma'am.
yeah, hi ma'am.
Yeah.
Ma'am, what do you think about these probiotics and how do we, we have a lot of product commercially available probiotics as well, right? So
Right, ma'am.
do you recommend that for children or because like my son, he doesn't have curd at all. So how do
Okay,
you
ma'am. Yeah.
introduce probiotics to them for their gut health? So what and all we can recommend?
So, ma'am, I think like gut health and obesity, though there have been some papers which have been linking,
Mm.
but ma'am, like whatever are the scientific consensus guidelines which have come out recently,
Mm.
AAP or IAP, like ma'am, they have not acknowledged the gut microbiomes as yet, but I'm sure like in
Okay.
the coming 4 5 years they would be.
Mm.
So, ma'am, like considering the overall, like I think for the, I mean, for the good gut health, I think if
Mm.
he's not used to eating the probiotics, I mean, the
Mm.
natural probiotics as curd and all. So, ma'am, definitely, I think our gastro colleagues can shed more light on it.
Mm.
But I think, ma'am, like probiotics would definitely have a positive role in enhancing the gut health and the overall
Mhm.
health overall.
So that's what, because I'm being a microbiologist,
Yes,
always
yes,
it's like the gut-brain axis. If you have a
correct.
good microbiome, the overall health is all, holistic
Always
health
good.
is better.
Yes,
Yeah.
yes, ma'am.
So there are a lot of commercially available probiotics now in the market, right?
Right, ma'am.
Yeah.
Yeah.
Thank
Yes.
you, Jyotsna ma'am. We have Sneha
Yeah.
ma'am connected. So
Yeah.
over to you, Sneha ma'am.
Ma'am, can you just share my PPT if you don't mind?
Sure, Dr. Sneha. Sure.
I have
Let me.
joined from my mobile.
Mobile, is it? Okay. Let me just, yeah. Is it visible, Dr. Sneha?
Yes,
Ma'am, you need to click it actually. We can
yeah,
see your screen.
yeah.
Sure. Yeah. I can keep clicking, Sneha. You can just give me the instructions whenever you want
Yes,
to.
yes,
Like, yeah.
yes, ma'am.
Monica ma'am, we can see your Windows, this downloads ka screen. We cannot see the PPT.
Oh, is it? Oh,
Yes.
okay. It's not visible as yet?
No, ma'am. We are seeing other screen rather than
Okay, just a minute. I think I'll just download it onto the desktop maybe. 1 minute, please.
okay, no problem.
Can you see my screen now?
You have
Can see the screen.
Okay, is it visible?
Yes, it's visible.
Okay. So is it visible now?
It's visible, but it's looking very
Very
Tiny?
Yes,
Yeah, very
tiny.
small,
If we
Sneha.
can tilt the mobile or something, then we can see.
Ma'am, can you just share it instead?
Yeah, Sneha. I'm again trying to. 1 second, please. Now?
Yes,
Yeah.
now we can see.
Yeah, sure.
Good to go, ma'am.
Yeah.
Yeah. So there are a lot of emotional and behavioral factors like, stress, self-esteem, family environment, which should not be neglected here, right? So we have to take care of all these factors when it comes to mental health and also social well-being. So the best thing to do here is the holistic approach to the treatment, right? So that we address all the issues that the child is going through. So next slide, ma'am. Next slide, please.
Sorry, Sneha, the slide is stuck. Just give me 1 minute. Yeah, sorry. Yeah.
Yeah. So the link between the mental health and the childhood obesity, we have to understand this as it is very important. So we all know about emotional eating, right? So even we do it at times, but children usually don't understand the way to stop because of anxiety or sadness or their low mood. They might be using it as a coping mechanism, right, which can lead to unwanted weight gain, right? And coming to the psychiatric disorders, obesity is closely linked to all the psychiatric disorders, be it depression, anxiety, psychosis, or any other uh, psychiatric disorders, also eating disorders, right? They play a significant role not only in weight issues but also has other psychological underpinnings like body image issues, cultural factors, which again has to be identified and addressed, right? Neurodevelopmental disorders, children with autism, ADHD, and also intellectual disability are higher risk to develop obesity because especially in autism and ADHD there is something called as impulsivity domain, which which makes them eat more. It is a problem with the reward mechanism, right? It is similar to addiction, right? Like there is addictions to the drugs, there can be addiction to the food as well, which can again lead to obesity. So coming if we can see some statistics here, up to 40% of children with obesity engage in emotional eating. Children with higher stress levels are 2.5 times more likely to have obesity due to emotional eating. And also, children with ADHD are 1.5 times more likely to develop obesity due to impulsive eating or poor self regulation. And up to 42% of children with autism spectrum disorders are overweight or obese. Next slide, ma'am. Social and emotional impact of obesity. So we all know what happens when a obese child goes to school, interacts with other people, right? They can be bullied. There might be a lot of stigma associated with their weight, right? So that can again lead to anxiety issues, depression, school refusal, social withdrawal, right? The children might form their own groups. They might isolate the overweight kid because of their looks or some other reasons, because they can't participate actively in physical activities like other children, right? This all can impact on their self-esteem issues and also have an impact on their social participation. They themselves might start to avoid school, social activities, right? And what happens when they start sitting in their home? They might be glued to their screens because that is what the best option they have usually, right? So sedentary lifestyle can again increase the risk of obesity. And the thing is internalized weight stigma. So children also might start blaming themselves, or they might start to develop some negative stereotypes about weight, right? Which again leads to low self-esteem issues. So around 70% of the children have reported that they have experienced bullying. And also because they avoid physical activities, social participation, that can lead to avoidance of physical activities, which can lead to difficulty in losing the weight, right? Ma'am, can we move ahead? Next slide. So the family dynamics and parenting styles. So the first thing that we do, especially when a child lesser than 12 years old comes to us, is we start working on the family, right? Because the family has the most important influence on the children, and only if we can change the family food habits, only then we can make some improvement with the child. So parental stress, their issues also has to be addressed. And a child's long-term relationship with the food depends on the parent, right? And also we should keep a check on harsh weight-related criticisms. Often it comes from the family than from outside. It often comes from the family, and that has to be addressed, right? And also we have to adopt some healthy parenting strategies. The first thing, if we want a child to change, the first thing that we need is a positive relationship with the child. If we don't have that, no matter what we do, what we don't do, the child wouldn't listen to our our advices. So to build that positive relationship is very important. And here what helps us is the parental management techniques. Usually these parental management techniques are used for children with behavioral disorders or autism, ADHD, intellectual disability, but they can be used universally actually, right? So there are like few sessions or about like 10 to 12 sessions that takes to complete a parental management training program, wherein parents are taught how to develop a positive relationship with the child, and how to modify their behaviors without offending them, right? So some studies suggest that parental behaviors, including physical activity, diet, sleep, mental health, significantly influence children's lifestyle choices and obesity risk. Children living with two parents are less at risk for obesity than children living with single parents. So all the family dynamics are going to have an impact on the child's emotional health, and also indirectly on obesity, right? So next slide, ma'am. Sleep and its role in childhood obesity. So sleep is very important. The first thing that I would advise whenever a child comes to me, no matter with what, would be sleep hygiene measures. That is, maintain a timetable, sleeping on the same time, getting up at the same time, limiting the screen time before sleeping, or not consuming any kind of stimulants, tea, coffee, right? And not doing some activating be it physical activity, or watching a horror movie or reading a thriller novel. Such things have to be avoided, right? Sleep hygiene measures comes first, because improper sleep can have an impact on hormones like lack of sleep increases ghrelin, hunger hormone, and also decreases leptin, satiety hormone, and it promotes overeating. Poor sleep and impulse control, definitely sleep has an impact on impulsivity, right? Because whenever we don't get proper sleep, it impairs our judgment, it impairs our decision making, right? So improving sleep for better health. So as I said, sleep hygiene measures would come first here, and insufficient sleep has been linked to increased obesity risk in children. Parent sleep duration also, everything. If we want the child to make some changes, it has to be started from the family, right? This is called as modeling. So we always have to model our behaviors to the children. Only then the children will learn it. If the parents are not sleeping, if other family members are not adopting these healthy practices, it is very difficult to expect from the child to follow them. Next slide, ma'am. So the impact of early life experiences and trauma, this also plays a huge role, right? So neglect, trauma, parental conflict also can increase obesity by triggering stress-related eating behaviors. We'll see that in the next slide. And also emotional distress and appetite regulation. Chronic stress disrupts hunger hormones. Again, like it disrupts sleep as well. And all these are interlinked. Intervention strategies include early psychological support, resilience building exercises, trauma-informed care. What we need to remember here is once psychological or physical issues develop, we need not start the intervention. We have to first focus on the prevention strategies, and that holds good here as well. From the school itself, we have to focus on life skills training, right? That is very important here. So in this image, we can see that how poverty, inequality, adverse childhood experiences, access to healthcare and education, food access can all lead to increased stress levels. These all alter the neurobiology of the neurobiology and also the behavioral pathways in the brain, which leads to overweight and obesity. So here we can see how chronic stress exposure leads to activation of HPA axis, leads to increased cortisol levels, and also disrupt the sleep and dysregulated reward system, right? And also reduce prefrontal complex activity. See, the prefrontal cortex part of the brain helps us in executive functioning and also impulsivity controlling. So that is why, right, we say that like children are very impulsive, they can't take their own decisions, because prefrontal cortex is the last part of the brain to develop. It develops at the age of around 25 to 30 years, right? And increased stress is going to just make things worse for the children, right? Cortisol is increased, reduced prefrontal cortex activity, dysregulated reward system. See, the dopamine, again, the dopamine comes into play in all kinds of addiction, be it drugs, be it behavioral addiction, be it screen time, be it food addiction. Everywhere dopamine pathway is affected, the reward pathway is affected, the prefrontal cortex has a role to play, the cortisol, the chronic stress levels have a part to play. All this can lead to changes in appetite hormones, right? Ghrelin, leptin. All this also is interlinked with the sleep quality and duration. So this shows us how important the holistic approach is to treat obesity, right? And again, coming to the school support and the community support. So everyone, next slide, ma'am. I hope everyone saw the slide wherein I explained about the HPA axis and the sympathetic nervous system, how it has effect on the cortisol, the prefrontal cortex activity, reward systems. Ma'am, we can go to the
This
next.
is the current slide. Okay, sure. We'll go to the next, yeah.
Yeah, so the role of school and community support, this also is very important. We have to, take the support from the school teachers and the management, the staff there, right? And make sure there are, awareness programs conducted, school-based mental health programs are conducted, community involvement. We have to again focus on the accessibility, right? Because most of the parents or children, they are so clueless where to go, right? So positive peer influence, all this becomes very important when it comes to school and community support. Ma'am, we can go to the next slide. So the most important aspect for obesity and obesity is treatment aspect for obesity is CBT for obesity. And most of the many research articles have proven its efficacy, no matter what the cause is. Definitely, when there are medical causes, definitely we have to go hand in hand. But CBT for obesity, like here you can see the outlines. There are around like 18 to 20 sessions, but based on the child, we have to go slow or faster. Mostly it works well in groups because it is mostly affordable as well, because each session lasts for around like 1 hour and can sometimes be costly. for the parents to afford. So here I have, you can take just to take a screenshot of this. Like I have explained it like, in detail here. We have to take the detailed history. We have to explain what CBT is. How we have to teach the child how to record, and like we have to educate them about the cause, their concerns, right? And we have to identify the barriers, work on them, and we have to address the body image concerns, introducing, maintaining the activity. Sometimes we have to work on the motivation levels as well. That is something called as motivational interviewing. And next would be like addressing the primary goals. This is very interesting. I can give you one example. So a lady was taking a CBT with me for weight loss, and she lost the weight successfully, but she was still so dissatisfied. And once I started exploring her primary reasons for the weight loss, it was to improve the relationship with her husband. Once she lost the weight, the husband was still like indifferent to it. He didn't even notice that she had lost weight or something like that. So we have to explore these primary goals. For children, it can be looks, it can be like again the relationship issues, it can be like the fitting in with peer groups, or be able to wear a lot of clothes. So all this becomes very important. Maybe weight is just a part of it. Maybe there is a very big reason behind losing weight. So we need to identify those and help them to cope with such issues as well. Ma'am, next slide. So coming to some practical strategies for healthcare providers, we need to adopt a weight neutral, compassionate approach, right? That prioritizes the emotional well-being as well as the physical health. For parents, we need to be first it starts with the family. So whatever changes we are wanting the child to make, we need to start with the parents first, so that they can model the behavior for the child, right? So holistic treatment strategies are also very important, wherein everyone's role becomes important. As Monica ma'am and Rahul sir they mentioned before, pediatric endocrinologist, pediatric gastroenterologist, pediatric psychiatrist, dietitian, physiotherapist, for children with neurodevelopmental disorders, occupational therapists. So it has to be the whole team, right? Without which we just can't do much actually, right? So family based behavioral treatments become very important when it comes to child addressing childhood concerns of mental health or social health, because anything before 12 years we have to focus on the family. Even above we have to focus, but individual CBT also starts working about 12 years of age. Next slide, ma'am. Last slide. Thank you so much for your patient listening. I have put my contact number and my Instagram handle, wherein I keep creating awareness videos. So we always can keep in touch. Thank you very much, everyone, for your patient listening.
Thank you, Sneha ma'am. Thank you so much for the insightful. And now I request all the pediatricians, if they have any question regarding this session to Dr. Rahul, for Dr. Monica and Dr. Sneha, they can ask now. Or they wanted to type in the chat box, they can type.
I think, Kavita, pediatricians can directly unmute and ask the questions. I think that would be nice for interacting.
Yes.
Yeah.
Excuse me, ma'am. I'm Dr. Pratyusha. I'm calling from, I'm speaking from Ankura, KPHB.
Yeah. Hi, Dr. Pratyusha. Tell me, please.
Hi, ma'am. Hi. Actually, see, we get to see many kids, like during vaccination. We feel they are on just definitely above the 97th centile, which the regular growth charts, which we are following IAP,
Right.
5 to 18 years. Usually, we don't immediately plot BMI chart. We usually regularly in OPB just put the weight chart, weight per age.
Correct.
So when we see that, suppose if the child is just below 97th centile, so it is the child has not yet crossed that centile, And when like we will tell them some dietary modifications, we will stress them about physical activity. When should we actually refer to that weight management clinic or endocrinologist? When should we actually tell them you should go and meet that doctor first? Or do we need to do any blood tests like basic workup like thyroid function test? Is it really necessary? I have never done, but is it really necessary? Like unless we have any other symptoms of hypothyroidism per se, just for weight, should we do basic workup, or should we refer? I usually get this doubt. When should we refer?
Sure, madam. So basically, madam, like as Dr. Rahul sir also initially emphasized, like how do we classify like the probable etiology of the obesity? So for example, if your same child who is obese in the toddler years, if he's like growing in height or length well, then it is little unlikely that it could be some sort of any endocrine problems per se. So that's why like
Yeah.
even if you do not do TSH, it is okay. If your child is developmentally normal and he's gaining his length and height well, of course, in the rarer cases, we do have some occasional surprises, but that should be okay, madam. And how do we, and when is the point that you would like want to refer us, madam? Like you see for the other red flag signs, like for example, like many times the if you just dig deep into their intake history, like the calorie amount of calories they take. So many times we see that like if the parents are telling you like well and good, like how many times he's eating and all, and if you see that there is a frank overfeeding which might be contributing to the weight gain, it is okay. But sometimes we do see that the child may have been exclusively breastfed till 6 months of age, but still his weight at say 6 months of age is about 9 or 10 kgs. Then that is something like, it is a mismatch that the amount of calories the child is taking and the weight gain is too rapid. And second
Yes,
thing,
sir.
like as I said, like if there is any height, reduction in the height velocity like that. So if there is any such features of hyperphagia or there is a mismatch between the calorie intake and say you have already recommended them the lifestyle measures like in terms of like good diet as well as physical activity and you wait and watch for 3 months and if he is not like at least, so ma'am, as I said, the goal is not like weight loss, but at least maintaining the same weight. So if he's
Yes,
not
yes, sir.
maintaining the same weight, ma'am, then I think 3 months would be a good time to refer, ma'am.
One more thing, ma'am. I have seen some kids like around the 7 or 8 year old girls who have this acanthosis nigricans, like darkness on the neck.
Yes, yes,
So that typically says that it is not healthy.
correct.
I
Correct,
feel
ma'am.
like we should definitely work up that way these
Yes,
days.
yes,
That
ma'am, definitely, definitely.
that time I will definitely refer to you. Until we see those changes, what can we do? That's what I was asking.
Yes,
Like
ma'am.
until they develop that, usually in the regular vaccination visits, we keep seeing them. We will
Yes,
think that they are going on the overweight,
correct.
that graph line.
Yes,
And we will get lost follow up of them. Suddenly they'll come and
come
we
at
start
time.
seeing these
Yes, yes.
changes.
Right,
Yes,
right. And
yes,
many
ma'am.
times, ma'am, actually, you may see like lean kids in the beginning years, and then like parents are initially worried that they're not eating, and then when you see them again after 4 5 years, they would have gained weight. So, ma'am, like I
True,
think,
ma'am. True. And
yeah. So, ma'am, I think it's from 5 years onwards, like even IAP recommends that it is good to plot BMI, ma'am, from 5 years of age. Like whenever you have a chance to see the kids, and if you feel like even the child is overweight, I think that is the point when you can start the interventions with the family.
intervention. Yes, yes, ma'am.
Yes, ma'am.
Sure, ma'am. Thank you. That was a great session,
Thank you,
ma'am.
ma'am.
Thank you. Thank you for this.
Any more questions we have today?
Okay.
Any questions for Dr. Rahul?
I think we would like to again re-emphasize, this is Dr. Rahul Reddy. We would like to re-emphasize that whenever children are diagnosed on the growth chart, they come under the obesity category or even the overweight category. We, as first the pediatrician, should look for the red flags like the previous discussion. And even if there are no red flags, even if the child is obese, a multidisciplinary approach would help all these children in managing their weight. So we have come up with a weight management clinic at Gachibowli, Ankura, and also at Kukatpally. Dr. Monica is there, at Kompalish is there, where we have the help of a pediatric psychiatrist such as Dr. Sneha. She's our specialist across the branches, where we work as a team, a dietitian, a pediatric endocrinologist, as well as a pediatric psychiatrist. And once we work together, then we can actually do some good work and get results in these children. So when things are not improving, rather than just reassuring them, even if they are obese without any complications, it is ideal to refer every child with obesity to these pediatric multidisciplinary clinics, weight management clinic, in order to get results, because treating obesity is a very tough task. I am sure you all agree. So treating it is very difficult. So it's better to refer them to a specialist's hands, and it will take some time, their efforts, and that will show some results. However,
Sure, sir.
parent compliance will
Actually,
also very important in such a case. So
yes,
that
yes.
is what I would like to add also to this session at the end.
Sure, sir. Sure, sir. Basically, like what we are, I am personally what I am practicing is like when I see first point at the first contact, I tell them that your child is on the overweight, and then on the overweight part of the growth chart, and I tell them minimal changes, and I definitely ask them to come back after 3 months. If the second 3 months, the next 3 months visit, if I feel there is no change or the weight is still increasing, I will definitely refer. That's what I am actually planning to, or usually I follow that, sir. Will that be sufficient? Like, is it better to refer at the first? Basically, parents are also, they are coming to know that their child is on the overweight point. They are also not ready, sir, because they think that their child is healthy.
Agreed, madam. Like parents many times don't recognize unless like we point out to them and explain to them that this weight is
Yes,
unhealthy.
ma'am. And top of that, when we tell them, they will actually, some parents can also feel bad, like
Bad, yes,
why
yes.
the doctor is saying a healthy child as a, see,
Exactly.
they want to find out fault in even healthy child also. So,
Hmm.
these things
Correct.
will come up
Yeah.
if we start speaking anything negatively. So the
Hmm.
first visit, I definitely tell them these are the measures you should start doing, and it is not good. But
Correct.
second time, if I get to see them, definitely I will. I have asked them to meet endocrinologist twice. Our Gachibowli clinic only, I have given them contact number, and also I asked them to meet once
Yes,
the
ma'am.
clinic, the
Sure.
weight management clinic.
Correct, ma'am. Because I think, ma'am, that's very important. Like the family has to be ready to start the change. So only then I think, yes, yes, ma'am. And sometimes, ma'am, also like one more point on the acanthosis, I just wanted to reiterate that sometimes you may see that BMI may not be in the exact obesity zone. Like BMI may be just in the overweight zone, but still some of the kids come with like acanthosis, what we see. So
Yes.
because, ma'am, like BMI is not a very accurate marker of the adiposity of a child still. Like we have like others like DEXA and all are more accurate, like which tell us the fat mass. So even if you see a child who is like just at the borderline overweight but still having acanthosis, then I think it is better to screen for this, ma'am, like any insulin resistance. Yeah.
Insulin resistance.
Yeah.
Okay.
Yeah.
Thank you, ma'am. Thank you.
Yeah. Okay.
Thank you so much, ma'am. Do we have any more questions? Then we will close the session.
Is there any role of endocrinologist role in failure to thrive children? What is the role of a pediatric endocrinologist?
So, sir, failure to thrive usually requires both, like, I mean, sir, I mean, again, a team approach between endocrinologist, gastro, and diet team. Because, sir, I think, because the etiology of the failure to thrive is so vast. So usually, sir, here at Ankura, we do a team approach, sir. Like, I mean, endocrinologist sees the child, the gastro also sees the child, and then, like, I mean, once we do the corrective measures, then, like, I mean, we work up further for the child, sir. Sir?
Yeah, it's good. Like, is it a growth hormone deficiency or We don't know. We need to evaluate it,
Evaluate,
right?
sir. Yes, sir. Agreed, sir. Because like the
Uh,
textbook picture of the Western population, what they say, growth hormone deficiency child are usually short and obese. We don't see in the Indian scenario, sir. Usually our growth hormone deficient children will be short and thin.
Yeah, primarily, Jagdish sir, we need to look for hormone deficiencies as well as malabsorption in these children, and probably the dietary intake also.
yeah, okay. Yeah, we like many times we are referring them, but why endocrinologist? That's a their question like comes like
Hmm.
about the people. Pediatricians also like where to send is a challenge. Like there is big confusion about this failure to thrive children.
Right,
Yes,
right.
a lot of times growth hormone deficiency is more common than what we think. So, if the height is on the lower side, the weight is less, it could be growth hormone deficiency. It could be other systemic illnesses. So, definitely work up with a pediatric endocrinologist would be better. And gastro, we generally work up for the malabsorptions also. And in the meanwhile, keep the gastro doctor also in the loop in such cases. And that will be the right approach.
Yeah, thank you.
Thank you, sir. Do we have any more questions? And I have one regarding this because all pediatrician is asking when to refer to a super specialty. So that remind me of one podcast we did with the endocrinologist and general pediatrician. So we have a podcast we did where we are giving information about when a pediatrician can refer to super specialty. So it's in YouTube. If any pediatrician can wanted to have such information, they can have. And we are coming up with more podcasts like this, where a super specialty like gastro and how this pediatrician we have a correlation between the pediatrician and a super specialty. So those kind of podcasts and videos we are coming up for all the our viewers. So any pediatrician want to see, they can go and check our podcast. So this is small information from our end. And I think that's all questions we have for today.
Yeah.
And Dr. Rahul, do you wanted to add something?
No, I would like to say at the end that the take-home message for this talk would be pediatric obesity is a very challenging condition to treat, and we need good care with multi-specialists, especially with the help of Dr. Sneha. With some CBT involved in this children, in these children, it would be rather impossible to treat it. Just a dietitian alone would not be enough, and we would need good CBT from Dr. Sneha. And pediatric endocrinologist's role may also be part of it, but I would say they do offer a great team-based approach, a dietitian and a pediatric psychiatrist for CBT. So the going forward, I think the way in future would be tackling these obese cases with a multidisciplinary approach rather than individualized approach, either pediatrician or pediatric endocrinologist. And we should come up with more affordable services. So we do a package sort of service where they meet all the three doctors during a single visit. And going forward, also, that should be the way we take it forward. Yeah.
Okay, sir. Thank you so much. And I would like to thank all other speakers also for sharing their valuable insight with us today. And special thanks to our pediatrician who has joined us today. Thank you so much for giving us your time, and have a great day ahead.
Yeah.
Yeah, thank you, ma'am.
Yeah. Thank you, Kavita. Thank you, everyone. Thank you so much.
Thank you, everyone.
Thank you so much.
Thank you, everyone, for joining.
ఒక నిమిషం ఆగు.